people here. 25, which is probably a record for Highlight, do you think? Yeah, which is nice.
Not quite, but nearly.
Yeah, it's got to be close. But certainly it's a record for new names as far as I can tell. So good afternoon, everybody, and welcome to July's Health Inequalities Learning and Action Group. I'm chairing today's session. My name's Matt. I'm a GP at East Park Medical Centre in the east of the city. It's fallen on me to chair today because basically our regular chair, Mo, is not here. And hopefully he'll return to work soon and he'll probably take over chairship again. I've been working with the public health team for, how long has it been, Lauren? 2 years? Two and a half years, maybe? On a handful of different projects here and there, but central to that has been this group. The primary kind of objective of this group is just to get together, and we usually have teaching sessions, learning and action sessions on health inequality focused topics. But we've had a bit of a shift from our usual programming to bring this GPOP project to everybody, basically. So that's kind of what we're here to talk to you about. So our main objectives today are to convince you that it's worthwhile doing it, because sometimes we are met with people, and maybe there's some people in the room today who think the health inequalities is not their responsibility or doesn't necessarily affect the population at their surgery. We are going to outline what's asked from you in order to fulfill your obligations for the GPOP this year in order to get the funding. What I can't tell you is how much the funding is, because I don't know, despite the fact that I've been kind of pestering a little bit, but maybe we'll be able to find that out today, possibly, maybe, don't know, we'll see. And then Lauren from the public health team will take over for a few slides to present on where you might find some of the information required to assess the needs of your local population. Then we'll talk a bit about the template that's part of the ask for the project. And then we'll talk about where we can get help. We did briefly talk about, or we did talk about this project last time in HiLAG, but generally we've had a fair bit of feedback that the asks remain unclear. So what we're trying to do today, and I think the main takeaway message, is what is required from you to fulfill your obligation for the GPOP this year. So yeah, feel free to put your hand up, speak in the chat, unmute yourself. I'm not precious about it. If you want to interrupt, if you think I say something that's stupid, it's probably because it's stupid. And if that's the case, then please do interrupt me, and I'm happy to be interrupted. So if we move on, oh yeah, this session's being recorded, which always worries me a little bit because I don't always think about what I say before I say it, but it's always said with the best intentions. So again, apologies for that. Finally, we're expecting that there'll be some questions, and they may not all be asked in the chat, and I may not even have the answers there. We may not have the answers today. So if that happens, then we will go away and generate an FAQ and get back to you. Okay, so why does it matter? I hope that this is teaching most of you to suck eggs, but we're going to go through it anyway. So we kind of talk about the wider determinants of health, is what it kind of historically has been called, and these are all the factors that influence a person and change their health outcomes, quality of life. All that kind of stuff is deeply tied and deeply rooted in the things that you can see here on the slides. So your surroundings, your housing, family, friends and communities, food, education, skills, work, transport, and then money and resources as well. All of those things have a huge impact on your health outcomes and everybody's health outcomes. There is a slide somewhere that we talk about, and it maps deprivation across the city of Leeds versus life expectancy. And actually, if you come from Harewood and drive south down whichever road that is that the A58? Whatever, south down there, here it is. Then your life expectancy drops by 10 years through the city. But you might look at that and think, oh, well, I work in Al Woodley, so why do I care? Actually, what happens in Al Woodley is you have a big gap. So there'll be people who are affluent in leafy suburbs. A lot of them will probably be doctors, and their neighbours or the estate next door will be pockets of deprivation or groups of marginalised individuals who experience the challenges that you face when deprivation is part of your world. The best kind of national example of that is Grenfell, which is in one of the most affluent areas in the entire country. But next to, I can't remember if it's Chelsea or Westminster, but next to there is Grenfell, which is a pocket of huge deprivation. And sometimes those challenges faced by those individuals are actually more difficult than those who live when deprivation is more ingrained, if that makes sense. You also see that in coastal deprivation as well, where there are like really affluent towns, and Cornwall is rife with this, where there's really affluent towns which are full of everybody's second houses, and then the population who are actually resident there face like pretty nasty challenges, really, because of that deprivation gap. So that's why it's a problem, because basically if we don't address these problems, then patients die younger, people die younger, their life is more difficult. And Lauren and I share our kind of like agreement and passion for this quote, and this is at the beginning of one of Michael Marmot's books. And this is what he says is the reason that he left emergency medicine, which is what he was doing, to go on and become a public health rock star. Why treat people and send them back to the conditions that made them sick? And the story goes that he thought of that while he was on an A&E shift, giving out his 50th round of antibiotics and steroids, and thinking, well, they're just going back into a smoky house in a damp area. We need to sort that out, or these people are just going to keep coming back. And there's a lot of truth in that. So that doesn't mean that it's your responsibility entirely to solve all of these problems. Of course it's not. We don't have the levers to pull on in general practice to solve really any of these problems, but we do see the sharp end. We do see those patients coming again and again and again. And I don't understand why my COPD is getting so much quicker, so much worse. And well, it's because of all the conditions that you grew up in and that you continue to live in. So the public health team, in collaboration with a few GPs, so as myself and Hasantha and Mo a bit as well, came up with this plan. And we've had really, really good support from our colleagues at the ICB, which is nice. And if you work in primary care, it can be we're really guilty of silo working in general practice. We're so busy with service provision and service delivery that we sometimes don't stick our heads above the parapet and see what else is going on. So I was really pleasantly surprised when I met the public health team how supportive they've been, and then also the support, like really the financial support that's come from the ICB to put this project together, which is great. It's nice to see that the ICB take it really seriously. So that's why the project exists. Let's see what's in it. Here we go. Step 1 is the self-assessment. Understanding health inequalities. Have you all completed the inclusion health training? Does your health inequalities champion attend the health inequalities learning and action group? Step 1. You don't have to do all of these things. This is just a kind of a guide to see how you're getting on now, and a bit of a benchmark to see what's going on in your surgery in your local area. So this is an online form that's due by October 2026. That's to be sent to Laura, who is part of the ICB team working on this project. Is Laura here today, or Kirsty, are you representing the ICB today? Super, thanks for coming, Kirsty. And then there's a bunch of other data stuff to look at. We're actually going to go into quite a lot more detail about the PCN profiles, practice summaries, and the 5 A's of access later, so we'll leave that. Do you all use the what matters to be toolkit? I mean, I'll be honest, we don't, like, if I was going to score East Park here on this self-assessment, we don't score particularly well on this at all. So I suppose the part of the project is to try and improve how well we do on these good practice measures. So that's the self-assessment, which you have to get plan on a page done about how you might address some of these things by October and submitted to the ICB. Okay. So these are the 3 big things that you have to do. Identify health inequalities champion and join the peer network. This is the peer network. So if you're here today and you've nominated yourself as or you have been nominated voluntary or involuntarily as your health inequalities champion, then welcome. Could I please clarify whether all staff are required to complete the health inclusion training, or is it only the health inclusion champion who needs to complete it? I don't think anybody's actually obliged. I don't think anybody's obliged to do that. We would encourage as many people as are interested to do that. And I would say probably it would be good if the bare minimum that your health inclusion champion did it. But I don't think anybody is actually obliged. Is that right, Kirsty? Yeah.
Yeah, no, I totally agree with that. I don't think we could, in terms of, I would encourage it exactly as you've said, as many people, but I think when we kind of put it in there, it was about the champion undertaking that training, and then obviously trying to disseminate that through team meetings, practice meetings, that kind of thing.
Yeah, and I think it's fair to say that the the spirit of this project is about improving everybody's engagement with health inequalities as a work stream. And actually, maybe that's a bad way to describe it, because one other thing that we talk about is that health inequalities is not isolated. It weaves through everything that we do. So the more conversations that are happening about it, the more people who do the training, the better. But yeah, I think just the champion is the bare minimum. Let's have a look. Mo's just put, is it a brief introduction to health inclusion? Let's have a look. Oh, Mo, you're here. Nice to see you, bud. How are you? So this is the one that Mo's linked, is the Fair Health website, which is fabulous, and their training is very good. Is it the one that we're expecting people to do, Kirsty, the Fair Health one? Or is there another one on the ICB?
I will have to go and double check when I click the link. So leave it with me and I'll come back in the chat. So
great. Thank you. If you have a particular keen interest, then I would encourage you to look through the training, all the training modules on that Fair Health website that Mo's linked, because they're really very useful. And there's lots of them about health inclusion, about how you might reach groups that have traditionally been marginalized. But yeah, there'll be more info about that on the chat, and I'm sure that Lauren, you can share the self-assessment link in the chat. Yeah. Right, she can't do it just now. We'll do it later. So that's the champion and the peer network. Identify the health inequalities template and agree a plan to increase utilization of the template. So the template, we will go into a demonstration of that very shortly, but we'll just put a pin in that one for now. Review the practice appointment system against the 5 A's of access, which we will also go into more detail again later. Those are the 3 things. So there's the self-assessment, which is required by October, and then these 3 things have to be done throughout the year. So if we move on, let's see what the next slide will bring. I promise I've looked at this slide, but this is over to these slides. This is over to Lauren to talk about how you get your data.
Hello, everyone. Just to also say on the last slide that although you are here as champions, or you've come in place of a champion, this is not purely the role of the champion. This is about like working with the practice as a whole. So it doesn't just sit with you. But it's great to have you all here. So thank you for coming. So I'm going to talk a little bit about where to find some data that can help you understand populations within your PCN, around your PCN, and practice to help just improve understanding of who you're working with and how you might prioritize some of the work that you do, and just really get to know what's going on around you. So this first thing, and just to say, we'll share these slides and all of them have links to everything that we are talking about, so you'll be able to access those as well. This first slide just gives a bit of a snapshot of the whole of Leeds from sort of like the life course model. So it looks from birth all the way through to death, and it looks at some key performance indicators around like public health, and also Marmot, the Marmot programme that Leeds is involved in. And it gives an idea of how Leeds compares to England. So the colour of each of these icons tells us if we're better, worse, or roughly the same as England. And it also tells us the direction of travel where that can be tested. So the arrow tells us if it's getting better, getting worse, or if it's there's no significant change. For quite a few of these, that measure can't be tested, the trend can't be tested, just because of some of the requirements of that. But it gives us an idea of where we are as a city. Obviously, life expectancy is lower than the England average, and there's quite a few on there where Leeds is lower than or worse than Leeds. So that is kind of an overview for Leeds. There was also on this resource, the last 2 pages give you sources for all of that data, so where it's come from and also the dates of it. So a lot of the data comes from things like ONS, Department of Health and Social Care, some of which isn't for this year. So a lot of it you can see is from sort of 2022 to 24, if it's over a 3-year range. Some of it's from 24, 25, and we'll update that annually so that you get the most up-to-date information. The next thing that we wanted to signpost you to is the PCN infographics that I think is mentioned in the self-assessment tool. They're available on the Leeds Observatory, so the link is there, and you just scroll down to where it says here, Primary Care Network Health Profile Infographics. So there is an infographic for every PCN in Leeds, and you can have a look at that. And I've got an example So we've got an example for Chapeltown. There's actually 2 pages. There's an adult page and a children's page, and it does a similar thing to the previous infographic, but this time it's comparing your PCN to Leeds as a whole, so the average for Leeds. So again, you've got colours indicating whether it's sort of worse or better than Leeds, and it just gives it's built around the core 20+5, so it's really aligned to that sort of NHS model way of thinking. And it gives you some really good insight into your population as a PCN. So there's things like, there are some things that are based on health conditions, so there's diabetes, mental health, things like that. There's also social determinant indicators like fuel poverty in there as well. So that's really worth having a look at. Another thing that you can find on the observatory is the area profile dashboard. So again, the link is there, but you scroll down, it's, in fact, I think it's quite at the top, to interactive reports, dashboards, and it's area profile at the top. There's loads of pages on here. This is one that I think is really helpful to look at. You can choose your geography type up here. So you would choose primary care network. You can also look at things like wards or smaller footprints if you like. You can then choose health conditions, and it looks at Leeds as a city, so it looks at all of the PCNs and how the sort of rates of that condition and how that compares to the average, which you can see is the dotted line here. Another aspect of that page is you can look at how health conditions within your PCN have changed over time, and also how they compare to Leeds. So you can look at trends in different conditions to help understand how things are going and what might be particularly concerning for you, I suppose. The next one, so this is Fingertips, which is the Department of Health and Social Care. This is where they provide public health data. There is tons on there, so I've just included a screenshot to show you all of the different profiles. You can click on any of these and just explore it. A lot of it's fairly self-explanatory, but it just gives you some the most up-to-date data that they have on these different things. So if you've got a particular interest or focus in say diabetes or mental health, then you could look at those profiles on there for Leeds. Also on Fingertips, there is the National General Practice Profiles. So these again are linked on the self-assessment, but they're worth having a look at. You can search for within your PCN, your practice. So for example, if you were to look for Mo, I chose your practice as an example, you can look at Woodhouse Medical Practice. Oops, and it looks like this. So it shows you different bits of data for your practice population. So this is narrowing it down to practice level. So there's things on here around just like the age profile of your population, deprivation, life expectancy. It's all sort of like summarized here, and ethnicity as well. And finally, this is a fairly new dashboard that's become available. So it's an inclusion health dashboard. This is for the whole of England, but on each of these things you can narrow it down to look at Leeds and also how Leeds compares to other cities. And it's a really good reminder that as well as deprivation being a really important driver of poor health, there are lots of other things that contribute to health inequalities. So particularly different sort of socially excluded groups or people who face marginalisation and deprivation in different ways. So there's information here around people experiencing homelessness, Gypsy, Roma and traveller communities, sex workers, migrants, people subject to modern day slavery, contracted with the justice system, all sorts. So it's a good place to have a look to just sort of get familiar with some of that data and remind ourselves of how important it is to consider these different communities in our approach to how we work. So this is one of the kind of intro slides, which I think is really powerful because it kind of gives a bit of a visual of looking at mortality rates for, ratios for kind of the general population broken down by deprivation. So you can see how, those in the highest level of deprivation have higher mortality, but actually when you compare that to sort of inclusion health groups, mortality is significantly higher. So it's really stark to see those differences. So I think that's all from me on the data. But I guess just to say that we're really happy to support in public health if you're struggling to find data or you need some support unpicking some of it. We're really happy to help with that. So do get in touch. You're welcome to reach out to me. My contact details at the end of the slides, and I can either put you in touch with colleagues who are sort of locality specialists. So we have different public health colleagues who cover different areas. Some of them are here today. Or even if it's a request for the public health intelligence team and how they can support you. Yeah, we're really keen to do what we can. And over to you, Matt.
Great.
Unless there's any questions. Sorry, I couldn't look at the chat while I was talking. Is there any data questions?
We've confirmed that Mo's linked the correct training, which is helpful.
Perfect,
and he's also celebrating Liz Keats in the chat.
Absolutely. Yeah. Thank you, Mo.
Okay, so now we're going to move on to the live demonstration chunk of today. So I'll have to share my screen. Which is this one. There we go. So this is system one with our test patient Minnie Mouse. I've been trying to think about what kind of health inclusion group Minnie Mouse might be included in. Her house is very, very small, and she's constantly being harassed by a cat. Well, that's Tom and Jerry, isn't it? Close enough, close enough.
Matt, I've just realised we've got a couple of slides to intro the template before we do a demo. Is that okay?
I've jumped the gun. Yeah, of course.
Getting too excited to show off Minnie Mouse.
Yeah. Oh yeah, okay, so this is about what it does and why it's helpful. So the health inequalities template, which has been a collaborative effort between the guys at the public health team, which is Lauren and Lisa, and then Hasantha as well, who's one of our GPs in Chapeltown. So we used Marmot principles to build a little engine, saves time, solves problems, and generates useful data. So I guess it has a number of benefits. So one is that it allows this bit is the bit that's slightly altruistic. So the data collection part of it allows the public health team to collate citywide data about deprivation and the problems associated with deprivation. That include, are you from a marginalized group? Are you living in fuel poverty? Is your house unsuitable for your family, etc.? Shall we send the link out to everybody at the end? We'll send the link out to the self-assessment again to everybody that's here. So yeah, it gives the public health team access to the data that they need in order to design services and build interventions that help our marginalized communities. Basically, that's the kind of idea. And what it does for us in general practice is it's a really, really practical template in that it has links and guides to dealing with the problems as they come up. And it's not like you should do X, Y, and Z. It's send them here. It's give them information about this service. It's sometimes email this person. And when we look at it, you'll see that there's really pragmatic information about how it works. The other flip side of gathering all the data, it doesn't just help the public health team. It will also give you an insight into your own practice population. You'll be able to know how many people are from the trans community. You'll be able to know how many people are from the Roma or Gypsy community. And at the moment, we're really bad at capturing that data. We don't really know. There's two ways of looking at that. You could say, well, it doesn't change their healthcare or shouldn't change their healthcare, so what does it matter? But the other side of that is we know that it does change people's healthcare. People do have worse outcomes when they're from those groups. And that, if we can acknowledge it and address it, then maybe we'll tip the scales back towards justice, which is what we're really trying for. So next slide, please, Lauren. This is I can demo this live actually, because I did actually figure this out myself. So go to the next one, Lauren. Oh, this is how to do it on EMIS, which I can't do because we're a System 1 practice. So it looks like you go to your resource publisher, Leeds ICB Central, ICB 2024, templates, protocols, health and wellbeing, health inequalities. I hope that those of you who are familiar with EMIS know how to navigate that, and that's relatively straightforward to find. But yeah, that's how you access it for EMIS. Next one. Okay, and that we can show this one live. Sure, I'll switch to doing it live then, Lauren. Okay.
Yeah, sounds good.
Bum, bum, bum. Here we go. Minnie Mouse. I was kind of joking about which inclusion health groups Minnie Mouse might be included in, but the reason we have to fabricate it is because we don't know, because we haven't captured the data. There we go. That's the truth. So there's two ways to access the health inequalities template if you're a System 1 user. One, you can go to this blue dot up here on the little patient flag, and you'll get this page here. And then if you navigate to H for health inequalities, you'll find it here. But I don't usually do it that way. I'm a big fan of the search bar System 1, so I just put health inequalities down here on the left, and then it brings it up. You can skip this page if you want to go straight to the kiddie or adult one, because they're both listed here as well. But we'll look at the splash page first. So if you do nothing else with this template, we ask you to fill out these 3 questions for the patients. Do you have money problems that make it hard to make ends meet? Do you have any housing problems? Do you have any difficulty understanding information about your health or any treatment you are receiving? At East Park, we are planning to include those 3 questions in our new patient registration process. So we are going to invite every patient that joins the surgery to fill those out. That is our way of rolling this template out. We, as you will all know, GPs by and large pretty bad at filling out templates. We kind of ignore them or do the bare minimum if we do. So those 3 questions are what we're asking people to fill out, and how you increase uptake in your surgery is completely up to you. Like I said, our method is going to be the new patient questionnaire, but there's loads of ways you could do it. You could ask your healthcares or nurses to include it in your NHS health checks, for example. You could ask your receptionist even to fill it out. There is a legitimate criticism that would be, well, what do we do when people answer yes or no? Or yes, well, probably if they say no, you don't need to do anything. But the good news is we have some solutions that can help. So let's take, for example, that someone says, do they have any housing problems? And we click yes. And they're assuming that they're an adult. We'll navigate to our adult health and inclusion inequalities, or you can jump using these little handy dandy shortcuts here for the housing, but we'll go through the kind of the older, slower way. Then you're greeted with this, and there are lots of different options here. So this one, we're interested in housing, so I'm going to navigate to the housing tab. And this can be a little bit overwhelming to start with. There's loads of questions here, but they're by and large quite helpful. Do you worry about paying your rent? And you have to free text that there. Yes, I do. Mickey has lost his job. So that goes in there. And then the useful information, that's after you filled that out. There's a bunch of different signposting tools here. So there's information on how to contact Care and Repair here. So Care and Repair will do small modifications to people's houses, handrails, a ramp, that kind of thing. So they're useful people to have, especially when, well, we know that adult social care can struggle sometimes to make these changes in implementation. Their waiting lists are long. So Care and Repair can help with quite a lot of that stuff. You can also repair for damp and mold, heating on prescription, fuel cost advice, energy saving equipment, and home efficiency improvement. This is probably the most powerful thing that I've learned. Please note, it's no longer necessary for a GP to write a letter on behalf of patients to the housing team. A letter has been created for any staff member in the practice to print out to give to patients so they can take it along to the housing team. It holds the patient's long-term conditions, medication, and fit notes. You click this button and it generates the letter that you can print out. So that can be, any member of staff can do that. I will confess that sometimes if people's needs are specific or complicated and that their summary doesn't do it justice, I do sometimes put a bit of free text in there, but you're under no obligation to do that. The housing team don't really want you to. And then there's other links here about useful support. So if you're not safe in your community, you can report hate crimes to the police via this platform. You can report antisocial behavior to the city council there. And then there's a long list of other things that you can do here. So damp and mold, you can report this way. Housing support, you can do this way. And a lot of these are just email addresses that patients can use and take. But yeah, that's what you do with them, which I think is, and Asantha was very keen to point out that this is the practical application. So yes, it's helpful to capture the information, but as you all will be aware, when you ask patients about that, sometimes it can feel like you're opening a can of worms. So here is what to do with that data when people share it with you. And then there is a bit of a information. Oh, this is just the same page, but slightly easier to read. And then there's also work and employment help, financial help, help for young adults. So that's the adult one with lots of good stuff there. I mean, if it pertains to a wider determinant of health and it's going wrong, you can probably find information about it here on the health inequalities template. There is actually a little summary here about what it's for. And if you click this link here, it actually links to a YouTube video from Michael Marmot talking about our Leeds program. And then this is what the child one looks like. So Breathe Easy Homes, which you're probably familiar with if you work with a deprived population, that's for mold in kids with respiratory problems. Best Start in Life Parenting Hub. So this is free breakfast clubs, getting kids ready for school. Lots of helpful stuff in there. And again, very young children, there's options here with similar signposting, help at the bottom, Icon, MindMate, Home Start, dealing with tantrums. My eldest is 3, and that's a big problem for me at the moment. but I probably will leave the template for now for my children. 5 to 18. So if you're slightly older, there's help here. Financial, housing. Then it's very similar to the adult one. But that's the inequalities template in a nutshell. Your obligation or the ask from you as part of this project is to come up with a plan for increasing uptake of the template. We're not setting any thresholds. It's not you have to do 100. It's not you have to do 5,000. It's we are asking you to make a plan for how you increase the uptake. It seems likely that the health inequalities strand of population health is going to continue beyond just this year. And it is likely that the objectives, or the rigid objectives, will increase in their intensity in the coming years. So this kind of cycle, if you like, is about familiarizing yourself, getting it on your agenda, and looking at ways that you can increase the uptake and the use. So that's the health inequalities template in a nutshell. And like I said, the ask from you for this is that you generate a plan for how you increase uptake of the template. I don't think there's any need for specific consent for this information. That all pertains to their health record and is all relevant. I think you'd be covered by your medical license, basically, to ask about this information. It's relevant to people's healthcare. Yeah. And this is what it looks like on, unless anyone else has got, an opinion to the contrary. If so, please chime in. But I would have thought that this is all relevant to people's healthcare, and as such should and can be captured. The data sharing that the public health team can look at is all anonymized, so there's no data sharing conflict or problem there, and that happened at a city level already. If the Department of Health and Social Care get their way, it'll happen at a national level in no time at all. This is what the landing page looks like on EMIS. The questions, as far as I understand, and the tabs are all the same. It's just outlined or laid out in a slightly different fashion. It's basically the same thing, but just with a different skin. Okay. Yes, so we're asking, the entry level is to do the 3 screening questionnaires, but they often lead to more questionnaires if people answer yes. The reports will be analysed quarterly. We'll say the first quarter's data is already in and the uptake's not been very good, but I think we have to put our hands up and say basically our fault because the ask has been unclear and the comms maybe haven't been quite as forthcoming as we would like them to be. Practices can build bespoke reporting systems, so you can report on your own. You'll all know how to do that. You'll have staff that know how to do that. The housing pathway, yeah, we said that's actually probably one of the more useful things. And as a prompt and a suggestion, we're talking about a pathway into non-clinical MDTs for how things can be best supported and signposted. I know that some surgeries and some PCNs are already doing a similar thing, and the Children's Hub through Asantha is Children's Hub, Children's MDT kind of looks at how patients can be best supported in a non-clinical fashion. Okay. Yes, so how do you implement the template? We've already really talked about that, haven't we? About how you might do that. So I think we can move on. In fact, I think we mentioned all of them, so I think we can skip that. Right, and then we move on to the 5 A's of access, for which I will hand you over to the capable hands of Lauren.
Thank you. And also, Mo, as you're here, if you have anything that you want to chip in, please do feel free. It was just to really quickly signpost to the 5 A's of access. If you haven't already seen it, this is in the document that summarises the scheme that hopefully everyone has seen, but I put in the chat that we can get Laura to send that out again to everybody, just to make sure you have had sight of it. So this was developed, Mo, a couple of years ago. It was, I guess, born out of the realization that people had different understandings of what we mean when we talk about access. So we wanted to really break it down into a format that can be used by practices, PCNs, and as a system to think about how we can improve access in different ways and what that actually means for population. So it breaks it down into approachability, acceptability, availability, affordability, and appropriateness. So it gives you these sort of questions that you can ask yourself. So particularly the ask here is to think about your appointment system and how people might be able to book in with you. So is the service easy to find? And then there's some prompts under there to think about, is the service culturally and socially inclusive? So thinking about different beliefs and different needs from different groups. Can patients access care when needed? So is there sort of flexibility? Have we thought about digital and language barriers? Are cost concerns considered? So just thinking about financial barriers, including transport, people needing to take time off work to access appointments and whether that's possible for some people, care costs, things like that. And is the service tailored to community needs? So I guess this is going back to thinking about patient participation groups and understanding your population health needs. So is it designed to meet your patients? And is it personalised, compassionate, for complex cases? So that is there for you to think through. We know, I think not all practices have a PPG, but if you do, there would be a really good place to take this to kind of work through some of this, and they can, I guess, advise on their suggestions on what they think would work for them. And just thinking about support, so obviously, this is the Highlight the Health Inequalities Learning Action Group. This session we've put on specifically for the champion, so we haven't invited the whole network, but usually this goes out to the whole network. There's over 300 people. These run online for an hour approximately every 8 weeks. We try to always record them if we've got permission to do that from our speakers, and we explore different topics. So this is going to be a really important way for you to engage in the kind of learning, the peer support, hearing from practitioners across the city who are sharing good practice. So we would really encourage you to take part in that. We will look at whether we can have some sort of Teams channel for like online conversation between meetings, because we appreciate that this is just a kind of every 8-week online session, and it might be that you want to pose a question to the group or seek some support in the interim. So we're going to look into that. We, as public health, can provide you with some data and insight if that is required. So we want to support you as much as we can. So that's myself and Lisa, but also our locality specialists and also our topic specialists, because we cover, public health is really broad and it covers all sorts of topics and population groups. So wherever we can help you, we will, and you can kind of come through us as a central point and we'll get you to the right person. We're happy to support with things like internal target sessions, coming to your PCN team meetings or practice meetings, or like one-to-one or small group support, perhaps if like a group of champions within a PCN want to come together and just talk about like thinking about your action plan, like what do you want to do for your practices for, say, increasing utilisation of the template. We're really happy to support that. So just reach out to us and we'll do what we can. And this is all about us like working side by side to connect the systems. This isn't a kind of, it's very much a collaborative thing. We want you to feel like we are here to help you through it. Obviously, it's a new scheme for us all, so there may be teething problems, and do let us know if you're having any issues or you need anything else from us. So I think we're going to go on to question time.
There's just one more point that I wanted to make, actually, because Mo's just emailed us with the paper. that was written by the Institute of Health Equity when they were kind of doing their work on Leeds and Marmot City, and specifically about what that means for primary care. And it's a very kind of, it's not very brief, but it's pretty brief and pretty easy to read summary of the work that's gone on. And it specifically talks about your PCN splash pages. It talks about the 5 accesses. It talks about the health inequality templates, although that's a little bit out of date. But we'll probably share that in our follow-up as well, because that gives you a lot of information about the background and why we're doing this project, basically. So yes, please, questions. Actually, Lauren, could you just bring up the objectives? You know, we talked about the objectives, so we'll just because I want it to be really, really clear what we're asking, because I think often people come away from meeting where Lauren and I have talked passionately about the work that's been going on, but at the same time you go, you know, what we've talked about all the stuff that's important to us, but have we talked about what you need to do? So you need to complete the plan on a page self-assessment. Those are the questions that we showed at the beginning. Identify health inequalities champion and join us at HiLAG. Review the health inequalities template and agree a plan on how you increase uptake, and review your appointment system against the 5 A's of access. So those are the, if you take nothing else away from today, take away the fact that health inequalities kills people young, and in order to achieve the objectives for your GPOT this year, you have to do those things that are listed there. Louis Shipman says, when you said one of the main aims is to increase the uptake, is this being measured? It is being measured, but not against any KPI. There's no threshold. We do check it quarterly. But like I said, this is building up maybe to some more work in the future. So if you've got it embedded, then it will be helpful. So Lauren caught me off guard yesterday. She told me how many has been done, and I said, I think we've done 3 at East Park, and I was right. We've done 3 in the quarter, so we still have to we still have some work to do.
And shout out to the Chapeltown Family Surgery, who have done 10, which I think is the most. So well done, Hasantha.
And that is because he designed a template. So any other questions are welcome, or comments or criticisms or anything. We've got thick skin.
And feel free to put them in the chat or unmute yourself, or even you can email me, or there is also the form that we sent out where people could submit questions. So if you've not completed that, please do share any questions.
Nadia, come on in.
Hi everyone, apologies I've not got a camera today. I'm just thinking in terms of the template and things like that. I'm just wondering about encouraging other PCN staff, so as well as like obviously the practice staff, who often are short of time, as you alluded to. We've got sort of a team of social prescribers, and so obviously across the city there's linking leads and things like that, as to whether we could encourage other people to be using the template when they're having contacts, and even, you know, sort of thinking wider across the LCPs, whether, I know obviously a lot of the third sector organisations don't use System 1 and EMIS, but where there is opportunity to fill it in, whether there has been that kind of encouragement for sort of other people to fill things in.
I think certainly it would encourage PCN staff to do that, and really anybody that's got access to their medical record, or at least in part to their medical record, can fill out the template. And I think that's a really good idea, doing it at a PCN footprint. Yeah. It'd be tricky to get people in the third sector when they don't have access to their healthcare record. I suppose a printout maybe, but then it's it's admin time for people at the PCN or the practice to then input that, isn't it? But yeah, I think PCN staff's a very good suggestion.
Yeah, and I think, Nadia, it's a great suggestion in terms of the role of the third sector and wider community organisations. And I think it needs some thinking time, but because there's something there, isn't there, about there's so much insight that they have when they're working with people that, you know, we would benefit from holding within primary care, but it's just how that happens. And I probably going back to your point before about like the consent to share and stuff, it gets a bit tricky, but I think there's something in it. And I've just been on a call this morning for some other work that's been happening in London and elsewhere in the country around sort of screening for social determinants, and that came up there as well. So watch this space, but I don't think we're there yet. But definitely in things like the non-clinical MDTs that have involvement from, LCP partners, that's a really good space to capture some of that and feed it back through into the template.
Yeah, certainly. Certainly. I know Kirsty will be well aware of like the proactive care work and neighbourhood working. That is obviously the kind of the thing to be doing over the next 2-3 years. There certainly will be scope maybe to kind of include this and kind of the two can go hand in hand. She's nodding. I can see a nod.
Yeah, no, I think it's great, isn't it? If you go back to the kind of ambitions of the 10-year plan in terms of from sickness to prevention, this is truly the prevention bit ideally, isn't it? So I think for me it's where do we go next in terms of how do we develop the scheme, how do we get this embedded and really try and think through how we measure some of this and yeah, so I think it's a great point in terms of linking the two up, Nadia. So it's definitely food for thought, I think, around how we evolve this into that proactive care work going forward. So yeah, leave that with me, definitely. Thank you.
The neighbourhood working model as we go forwards, I think there's lots of things that need to be deeply embedded in the way that we do that. Health inequalities being at the fore. I think the more of us that advocate for it as these services are being designed, the better. And I think having a really concrete offer like this is probably helpful on that. I think it's a good idea. Ramona has asked, may I ask which report we should use? Is it DQH101, HI01? That will tell you how many times the report has been filled out at your surgery in the specific time frame. So yes. If you search that search on System 1 and you run it, it will tell you how many times the template has been run in your surgery in that specific time frame. So the answer to that, I guess, is yes. It won't report on the specific codes that have been documented in there. It will just report on how many times the template has been filled out. And then does the template have a box to tick to indicate you have signposted, i.e. are you measuring that action is being taken rather than just the info recorded? Sorry if that's missed. I don't know the specific details about it, but what I do know is that if you open the template and close it and then save it, that counts. So just reviewing the template does help. I'm just going to show you again, actually, the Mickey Mouse or Minnie Mouse. So what do I want to share? You don't want to see my emails. You want to see, probably don't want to see, but I'm going to show you anyway, System 1. So these codes here at the bottom are the two that are recorded if you open nothing except, if you do nothing except open and close the template. As for whether you've signposted, well, we can check it live, can't we? So let's have a look. So this person, let's say she had problems with homelessness, and what we're going to do for a letter for housing, that will be coded. That's coded. So I guess it depends on what actions you take, but most of these things have a way of being recorded. So the answer depends on what you're doing, but most of the time the answer is yes. Okay. Okay. So, oh yeah, Laura answered that already. Sorry. So then, have payments been finalised now? Do you mean the value of this scheme for future year's scheme or this scheme?
I think Kirsty wants to come in.
Yeah.
Yeah, thanks for asking, Mo. So I know when I came to the group last time, I explained that. So just to be really clear, this is a bit a scheme that's separate to GPOP. So GPOP's been finalised.
That's on me.
No, it's fine. Everything gets lumped together as GPOP. So I'm just kind of pedantic about it, so apologies, forgive me for it. But I think when we're talking about the money, it's helpful to be really transparent about it. So obviously GPOP's separate. This is some health inequalities monies that we haven't kind of picked. It's based on a formula, based on list sizes, IMD, etc., from a number of years ago. So what we're just trying to do is remodel that so that we are, the point was this was about additional investment going to, proportionately weighted towards, so everybody got something, but it's proportionally weighted to areas of higher deprivation, ethnicity, and first language spoken. So we're just remodeling that. Some of the data's taken a while, so I suppose I'll make a commitment that we'll get that out in the next few weeks. I think what we're really mindful of is trying to make sure we're doing that proportionate shift. I think there have been some changes with some practices, so we do need to have a bit of conversation with a couple of practices. So all we're trying to do is be fair and make sure we communicate that directly, but we will get that out as soon as possible. So yeah, apologies. Like I say, it's just because we are trying to do the right thing in terms of distribution of the resource, because it was meant to be about supporting health inequalities. But yeah, I think because of mergers, etc., it's kind of complicated things even further. Do you want to come in, Mar?
Thank you. Thanks so much. Can I just acknowledge the really good work that's gone on to get us to this point? So it feels like a really good point where we've brought everything together, where like we started off as a kind of people who are interested in inclusion health, whatever you want to call it nowadays. And then it's like kind of coming to fruition now, where we're like living and breathing it. There's some money behind it. There's some expertise and loads of interest. So it's really, really, really good. And well done to the team for being able to get us to this point. I think so. Can I just double check just on that, on the monies kind of thing, because unfortunately money talks. So everyone will shut down when I'm trying to talk about this, unless it's, well, so how is this going to be resourced? And that's a difficult place to be, isn't it? But it's the world that we're in. So is it new money, or is it money that's kind of was given to the region that was paid out? I know there was some health inequalities money that was paid out that we use and that to PCNs. So is it like new money that you're going to have a look at and then kind of distribute, or is it like legacy money, or just to double check?
Yeah, so this is, and we were really clear about this, Mark, so I don't want you to think that we've, so I think how we've phrased it in the documentation is very clearly right. This is money that has been going to practice for a number of years, but it's just been paid over. There hasn't been an ask, things like that. So when we re-looked at all schemes last year, we didn't do this when it was paid again, paid out again. So that's what I'm trying to say around, that's why we're being sensitive about it, because we do need to...
that makes really, really good sense. Yeah, I totally understand. And can I just double check then? Is it mandatory? So if you weren't to do it, would the converse be true then? So if you don't do this, you're not going to get the money that was previously paid over without any ask?
Yeah, that's exactly right. So what we've done is reset it this year, where people have signed up, and we have had all practices sign up to it. But yeah, if people opted not to participate, then that funding wouldn't flow through. Yeah.
Okay. Amazing. Thank you so much.
And thanks, Mo, for clarifying that, because I'll put my hands up and say that I did not understand that that's what had happened. I thought that this was a GPOP incentive that had changed, but that's not a shade at Kirsty. That's just me misunderstanding. So yeah, sorry about
that. Can I also say that like this is just the beginning? So like this is something that you're doing like in the practice as you're the champion, but it's like only the beginning, and there's so much literature out there. I'm seeing that like life expectancy is actually falling in the UK. There's so many different things around this, so it's quite exciting. Yeah, so if you live and breathe it and then be part of this kind of group, I think you'll really enjoy it. That I wanted to just share something with you. Last Monday, a patient of mine, I was late seeing. He was a young chap, And he started shouting in the waiting room because I kept him waiting. And then he sort of like bothered my staff as well, like the PST, and they were getting a bit sort of like bit worried. Anyway, I brought him in, calmed him down, and then kind of saw him. And then he stood up at the end of the consultation and said, you know, who am I going to complain to that you were running late? And people are more complex now, and I don't know, I can't keep to time. I don't know if everyone else has a similar experience. And I didn't really say much, but then I understood why he was so upset, because he was in a temporary job. He's a barber. He'd taken an hour off work, and he was worried he's going to get sacked now because I was running late, and he's going to be late to work. And it's not to sort of excuse the behavior. I don't think that behavior is okay, but it just made me think. And when I understood what he was saying and doing, he didn't complain, and then there was a meeting of minds, and I understood. And I guess like it's just to see behind what's going on, and it just really made me think. Actually, I just wanted to share that with you.
Did he get fired, Mo?
Hopefully not.
Thanks for sharing, Mo. Ramona, come in. You're still muted.
Oh, sorry, I pressed it twice. Apologies. I wanted to ask about the fairer practice toolkit. I've registered and wanted to clarify if all those actions are mandatory. I made a start. There are about 40 something, I think. I can't remember how many, and it's a great tool, but I was wondering if there is a deadline. So I want to know how I need to prioritize. Is it the same deadline or end of October, or can you give me some clarity, please?
There's no obligation to do any of the Fairer Practice Toolkit from the RCGP. It's just I can't remember, it is the RCGP, isn't it? It's not.
Yeah, it is.
Health.
Yeah, it is. Yeah.
It's just the gold standard. You know, like if you really, arguably, what that toolkit lines out is maybe more impactful than some of the stuff that we're suggesting, because ours is a bit light to touch. So if you want to go above and beyond, then the Fairer Practices Toolkit is the way to go. And you know, I share your feeling about being overwhelmed slightly, Ramona. I've looked through it myself and thought this is a lot of work, but it is very, very worthwhile work. It's just a lot of it.
Thank you.
Just to add on that, Ramona, so with the Fairer Practice Toolkit, when we spoke to Dom, who was leading that work for RCGP, what he was saying is that the work that we're doing is so well aligned to that toolkit that they're happy for, if practices are signed up to this scheme and doing this work, that you kind of, that is like good enough to just then be signed up to the Fairer Practice and get that. Does that make sense?
Yeah, thanks for that. I've completed some of them, and I think it was a great start. So I'll keep going back to it and update it. So thank you. I no longer have a deadline then.
Well, you've got October for the self-assessment, but that's it, unless you've already done that. Yeah.
I will soon. Thank you.
Yeah, great. Any other questions or comments? Lovely. Okay, well, I think
Matt, there was one in the chat that I just have now lost. 1 second. From Kelly, just saying, will there be any other peer network meetings for champions? So it's one of the questions that we asked in the form. So again, it'd be really great if you've not filled that in yet to fill that in, because we wanted to know how, as champions, you wanted to engage in the network. So having like the regular highlight sessions obviously going to continue, and we want to, like, you're all really welcome there. We want to make sure that we get the most out of them as we can, but we weren't sure whether there was a need for then anything additional. So I mentioned that we're going to try and set up a sort of Teams channel for like online discussion between champions, and then it might be that if there are certain things that are cropping up that people feel like they need more support with, we could put on like ad hoc sessions. But I guess we wanted to hear from people about what was going to be most beneficial, and hopefully we can use the highlight sessions to kind of do what we need to do with the champions, but with also that addition of an online space. Does that answer your question, Kelly?
I think just to add to that, I'd say it can be done if you want it to be done. That's the summary, isn't it? And Lauren was advocating for it, and I kind of said I think HiLAG fits the bill already. But if we find that there are unmet need, then we can put one on. I think that's the
because I guess we really want you to feel like you're part of a network now that you're all champions, and you might not know each other, so we want you to have space to know each other and learn.
Super. Okay, well, thank you very much, everybody, for your attendance and your contributions. It's really, really appreciated. It's much easier delivering these sessions when there is a bit of back and forth compared to just talking to either profile pictures or letters on the screen. So thank you all very much for your involvement. And yeah, do get in touch with either the Laura or the public health team if you've got questions. And if they're unable to answer them, then they'll forward them on. The normal HiLAG meetings are always on a Wednesday at 12:30, and it's every 8 weeks-ish. Okay.
Thanks, everyone.
Take care, everybody. Bye-bye.
Thank you. Take care. Bye.
Rebecca, do you want to stop recording for us, please?
Yeah, of course.
Thank you.